Hey everyone, it's Dr. Abbie Ross here, vestibular physical therapist and neuroclinical specialist, joined as always by Dr. Danielle Tolman, also a vestibular physical therapist. And we wanted to hop on here today to talk about a really cool event that happened last weekend, November 3rd and 4th. It was the Charleston Vestibular Conference. And Dani had the opportunity to go and learn from some of the top experts in the vestibular world. Because I didn't go, we're here to have this conversation today so that I can learn and so that we can share some of the knowledge that Dani took in to all of you. Hey, Dani.
Hey, how's it going?
It's going. So tell me, who was there? Who were the speakers and what were the topics?
So let me rattle off the speakers real quick. They did an excellent job of picking some top-notch quality speakers that span across a bunch of different disciplines and some areas of updated research. So Dr. Habib Rizk, he is with the Medical University of South Carolina, MUSC, up in Charleston, that hosted the conference. And his team, he had a wonderful team that put this whole thing together. He came out and he spoke on a couple of topics, which we'll get into here in a minute, as well as Dr. Michael Teixido, who is a friend of our podcast and just an amazing physician, does a lot of work in migraine and BPPV and anatomical mapping of the inner ear. Then we also got to hear from Dr. Janet Helminski, who does exceptional work in atypical forms and treatments of BPPV. And then we heard from an audiologist, Dr. Kristen Janky, who just absolutely blew my mind when it came to audiology and working with kiddos. So first, right off the top, I just want to say that this was a great and unique conference that really had an amazing span of different disciplines in attendance. I mean, in the audience, there were PTs, OTs, ENTs, neurologists, audiologists, and even some ophthalmologists from the area. And I greatly appreciated the range of topics that each speaker presented on. I truly felt I had something to learn, and I took home something from every single lecture with me that I could apply right to the clinic with patients immediately. It was amazing. At the end of the first day, they hosted a really cool networking event where we got to sit around and have some hors d'oeuvres and some cocktails and just start to connect with all of the other vestibuloholics that were there. And to cap off the conference on the second half of the second day, we spent the entire afternoon in the lab, and they had a different station set up. And it was so great on how they organized this because they limited how many people were in each of those stations for certain chunks of time throughout the afternoon. So we got a little schedule. There weren't more than 8 people per little lab section. And we kind of rotated from classroom to classroom or evaluation room or building. And we looked at different things that we might not all have exposure to. So I got to go look at the video V-HIT, or it's just the video head impulse testing. I got to look at the rotary chair and VNG testing. They had labs for regular treatments for BPPV as well as advanced techniques for BPPV. Dr. Rizzik did an entire section on just history taking, which is so important, which we'll get into in a little bit. But I have to say, from all the different conferences we've been to, and that these courses that we went to on weekends, or these competency courses, it was really unique to have that lab time and have exposure to some things that we don't normally get to see, which was really, really cool. Now we kind of have a better idea of what our patients go through and what they might experience going through these tests. It was really neat.
That is so neat. And I have to say, just hearing about this so far, I'm already a little bit jealous that I wasn't able to make it. I also think it sounds like a little slice of heaven for vestibuloholics like ourselves. The
Mhm.
lecture component, the lab component, the networking event, or happy hour type situation. It sounds awesome. So what were some of your favorite talks and takeaways?
All right. So if you guys are just listening for the quick recap, now is the time where you might want to switch off, because what I'm going to plan on doing moving forward is I'm going to go through each lecture and I'm going to talk about some of the strong takeaways I took from it and share some of the interesting things. It might get a little technical, but I think that if you're a vestibuloholic like us and you're getting into treating patients, you might find some of this stuff interesting. So let's start off right off the bat. The Friday lectures were kicked off with Dr. Rizzik, who talked about clinical anatomy and physiology of the vestibular system, which is hugely important. He laid the foundation for the entire framework of this entire conference. He gave a fantastic overview of the vestibular system and hit on some topics that were really great reminders. And I have to show you this slide of a cross section of the ampulated portion of a semicircular canal. because it was just so great in the way that it showed like proper anatomy. If you're thinking about BPPV and where crystals can be stuck or adhered to in that ampulated portion of the canal, it's so great to see something like this where the cupula is attached to the bottom of the ampulated portion of the canal, as well as the ceiling of that portion of the canal, and that we don't have these terrible textbook illustrations of depictions of endolymph flowing over the top of a cupula. I thought that was really great. Right off the bat, I knew this was going to be a really great talk. I expected nothing less, but I wanted to share this with you. I actually screenshotted it because I was so excited. I haven't seen something like this before presented, so this is really, really cool. He spoke on a couple of different topics, including the concept of velocity storage and how nystagmus can be generated from an asymmetry in velocity storage, which, there might be people listening and be like, duh. But this concept is so important to the foundation when we think about spontaneous nystagmus and why we perform tests that work, like the head shake test, which helps identify hypofunction. But what made me perk up when he mentioned velocity storage asymmetry is how it relates to migraine. And it's very common to see non-localizing and various types of nystagmus with migraine patients, which can sometimes disorient a clinician with a bedside or infrared goggle exam. So Dr. Teixido got into that a little bit more later on in the conference, but I think it was just a nice light bulb moment where I kind of put more, two and two together. And I know we see weird nystagmus sometimes when somebody's symptomatic during a migrainous episode, but that kind of just put that more into context for me. And then kind of getting into some more of this weird nystagmus that we might not be, used to seeing all the time is just the concept of a light or a heavy cupula. And we can all relate to knowing what a heavy cupula is when otoconia adhere to the cupula, changing its weight and its density. But what would make a cupula light? I mean, besides alcohol intoxication, which, I'm sure everybody's not so aware of that. But besides alcohol intoxication,
Definitely not I ever.
No, I can't, put a finger on that one. But talking about or discussing that inflammation can sometimes be a common issue during migraines, attacks, or episodes. And on a cellular level, the increased inflammation can change the density of the endolymph. So if we've got this cellular level of inflammation going on and it's seeping into this endolymph, causing it to be more dense, then that means the cupula in relation is lighter in comparison, which we all know is a problem. Cupula should not be floating at all. So that was another light bulb moment for me, because I know I've seen plenty of patients with like a very faint, persistent geotropic nystagmus. And a lot of those cases, or most of those cases, migraine was definitely suspected. Then he really dove into history, which I was very grateful for. I think that everyone needs to really, really dig into that history. You and I talk about it all the time, that if we just let a patient talk long enough, they'll tell you exactly what's going on. And he gave some really great examples of keywords that we often hear from dizzy patients' histories, but they're not always in the textbook examples, or they're not always taught in the courses. It was important to me that he went over this, not only because he relayed the message that there's more to listen for when it comes to the dizzy patient than just your traditional room spinning type symptoms, but more so that it's very important to listen, period. Listen to your patients. Let them tell you what's going on. He also made a really cool point, which I know we put into practice when we think about it, but putting it into a succinct sentence like this really made me light up. He talked about distinguishing between the difference between positioning dizziness and positional dizziness. So, which is the difference between having dizziness while moving into a position and having symptoms after achieving a new position. Right. So a lot of people might think you can lie somebody back into a Dix Hallpike because they say they're dizzy. It's a positive test, but they might have gotten dizzy just coming down or coming back up. Once they were down, if they were asymptomatic, that could be a big determining factor between BPPV or something like motion sensitivity due to hypofunction or something along those lines. So I thought that was really neat for him to kind of just really greatly highlight that and put that into words. And Abbie, you would love this next bit.
Wait, before we go on, I want to
Yeah.
add something. I want to add something to that. I think that's such a good point about positioning versus positional. And when you do the motion sensitivity quotient, you're prompting the patient to give you a response as soon as they get into the position. So it's not after they lie back or whatever positional change they're doing. It's as soon as they're in the position, did they have symptoms? And that would insinuate that the symptoms occurred because of the motion, not because of the new position that they're in, if that makes sense. And then the other thing that I thought was, or I wanted to touch on in a conversation with Dr. Rizzik before, who, by the way, is an otolaryngologist. So kind of cool that he's talking about migraine in his lecture. I love that. But he had mentioned before that he will just let a patient come into his office and speak for, 5 minutes, 7 minutes, whatever it is. Just let them get it all out and vent. Now I have tried that, and from a note-taking perspective, it doesn't work so well. But how good would it feel for the patient to just be able to get out all the information that they can, and then as a clinician kind of guide them with questions so that you can process what's happening and lead into your examination and then eventual treatment approach. So really cool.
Letting them feel heard, I think, is a big part of the healing process in this journey of finding their way back to balance with vestibular dysfunction. And everything that he said in the history portion became significantly stronger with this next little bit of his presentation. So Dr. Rizzik actually had a really bad episode of vestibular neuritis a couple of years ago. And so in true vestibuloholic fashion, he had his team test him, and he tracked how his vestibular function degraded over the first couple of days, and then what that looked like over time and how it healed. So he was putting up his very own calorics and VHIT testing and everything up on the screen for us to see, how initially it presented, how it took a couple of days to really kind of lose all that function and what that looked like coming back. But it was so funny and so refreshing to hear his perspective as an MD who also went through this as a patient. So, just throwing this out there, we should probably give him his own episode on Talk Dizzy to Me to have him come on and talk about it, because how many MDs out there are willing to be open and talk about their experience with the very condition that they end up treating on a daily basis? I think that was really, really cool.
Certainly his empathy for his patients must have grown tenfold. And also how cool that he had the ability to reassess certain vestibular function tests to see the regression or progression throughout his course. So cool.
Especially in those first couple of days. If I had an acute case of vestibular neuritis, I'm not sure how quick I'd volunteer to go through caloric testing a couple of days in a row. Like, oh my goodness, like that's rough. He's a real trooper. In the name of science.
Yeah, in the name of science and vestibuloholics.
Yes. And then he closed out this talk touching on the link between the vestibular system and the link to cognition. So he threw a couple of things out there, which I thought were really interesting. And he talked about how age-related degeneration of vestibular-related cell and neuron bundles start after the age of 65, and the saccule appears to be the most effective. So if we think about, aging vestibular systems and potentially otolith involvement, what that looks like for patients with otolith dysfunction and just having general imbalance and symptoms. He also talked about the presbyvestibulopathy and the diagnostic criteria. If you're listening, you should definitely go and check that out. Look up the diagnostic criteria, because I feel like it covers a lot of my patients where I'm like, what's going on here? I'm not really sure. You're old. I mean, we just need to, jumpstart things to get things moving. He also he talked about 20% of patients presenting with vertigo have reproducible and significant cognitive error in arithmetic abilities, short-term memory, and performance in specific visual environments. And then this one I thought was very, very interesting. This it's not fun fact, but it's this fact. But he mentioned that Alzheimer's disease is twice as likely to have vestibular impairment than healthy control. So patients living with Alzheimer's disease are more likely to have issues with vestibular function, which I think we see a lot in that patient population. So his talk was probably the best way to kick off this conference. It was absolutely wonderful, full of really rich information. I encourage you, if there's, I'm not sure if this is something that can be done, but if there's a way to purchase the recordings from the conference, or were those who are attending virtually, this is definitely worth going back and listening to, or just attending the next one that pops up. So next up on the docket was Dr. Michael Teixido, and he talked about crystal clear BPPV. So straight BPPV, nothing funky. We are waiting for Dr. Janet Helminski to get into the funkiness. But first, can we just start by saying that Dr. Teixido is the GOAT of BPPV education. I mean, I have to say, I was very, very amazed at how many different things he had for us as clinicians, as well as what he does for educating patients. But first of all, he brought in these cute little pocket cards that you can use
Oh,
and hold
so
up.
cute.
How neat are those? So when you're in
I
these
love it.
positions, you can look at, it'll tell you which is the fast phase of nystagmus shown for different types of BPPV. So if you need a little quick guide, you can hold this up while you're watching your video and follow along. So I thought that's amazing. Not only
By the
that,
way,
yeah.
just his ability to effectively communicate education in general from all vestibular realms is incredible. What to this day, one of my favorite Talk Dizzy to Me episodes is the vestibular roundtable we did, and he was involved in it, and I just learned so much. He's amazing.
Every time he talks, it's like a light bulb moment after a light bulb moment. I love it.
Mhm.
I was very excited. I did not even know that this was available yet. I was surprised along everybody else who came to see the vestibular first table in the little sponsorship area. But Dr. Teixido's 3D printed membranous labyrinth model is now available for purchase. This is so cool. When we first had him on Talk Dizzy to Me, he alluded to mapping out the membranous labyrinth in the vestibular apparatus. And he was working on a paper, and he was working on all different things that he was going to use this for, including the mapping for his BPPV viewer, which we'll talk about in a second. But Vestibular First has created a 3D printed model where they've color coded each of the different canals. They have the area where the cupula sits within the ambulated portion of the canals. They have a directional area to kind of line you up for anatomical position, which, when you put on its cute little stand here, perfectly sits anatomically level as it would sit in your head if you were sitting up and looking straight ahead. So I think that this is just absolutely amazing. The thing that's amazing about this too, and I think that ties into his talk, is that these canals, unlike our bony labyrinth here, right? The bony labyrinth, you can see the canals are still round and a little funky, but it doesn't quite show just how funky the labyrinth is, the membranous labyrinth is. Like, check out this horizontal canal as it sits level. Like, that is wild, and how it's bent and so, kind of out of shape. Same thing with this posterior canal. It is anything but a straight circle. I mean, look how much that bends in different directions. It is amazing. Highly recommend buying this from Vestibular First. It's so much easier to see why things can be different with our repositioning maneuvers. So huge shout out to that. That was a really fun surprise. I just got it this morning. Very excited that that was on my doorstep when I came home from work. Also, okay, so like I talked about, BPPV Viewer, you can go to bpppvviewer.com, and it is a really cool simulation where you can create any kind of BPPV that you want by dropping otoconia into canals and repositioning the head and practicing repositioning maneuvers. Love this. Love this, love this, love this. You have to check it out. He uses it in his talk a lot to describe different types of BPPV. And then the last thing I'll gush about is his idea that he uses in his clinic for homework for patients. He's got a big, it's just an 8x11, standard piece of paper. And it's got all these QR codes on it with little empty like check boxes next to it. And it's all QR codes that lead to his patient education material or exercises. And when he sees a patient, all he has to do is check the boxes of what he wants them to do. Patient takes it home, and they can access all of his amazing patient education and exercises right from that one sheet. Brilliant. I mean, absolutely really cool.
We may need to implement something similar.
We may, because it just made a lot of sense, and it was just really, really neat. And I always send the patients to his patient education page on his website. It's phenomenal. I love his migraine information article. It's like my starting foundation block for a lot of my patients who are just getting diagnosed. I use his stuff all the time. It's just superb, evidence-based, and always updated. I can't recommend it enough. So let me jump into I'll do some really quick takeaways from his talk. Because again, it's one of those things where you need to be there, but there's a couple of really good points. It was interesting. He talked about superior neuronitis, so the superior vestibular nerve, that becoming inflamed. It is more likely to have otolith disease and more likely to create BPPV. He talked about the hexagonal shape of the otolith, which we had some examples of those printed out and handed out at the conference from Vestibular First. See if I can get one that's a little bit. The hexagonal shape and the flat edges of these little otoconia can affect the drag time as they fall through the canal, which is probably why, or a good explanation why it falls slower, making us kind of have to wait in all those positions for our repositioning maneuvers. And then he also talked about how migraine has a 3 times higher incidence rate of BPPV. He said BPPV accounts for up to 20% of all dizziness. And then he got into some of the null points for the anatomical positions for the semicircular canals, and then discussed various types of different maneuvers for various types of BPPV in all the different canals. One thing that I thought was really cool that I didn't know before was a treatment that he implements for a bilateral posterior canal, and he'll do just the rapid sit-up maneuver to treat both posterior canals at the same time, which is great because if you can take care of everybody all at once, why not? So that was really interesting. I'll move on.
Do you remember what position are they starting in?
So you have them back in like a deep head hang, and we put together some information and kind of link this. But you put them back into a deep head hang, and then you do a you have the patient rapidly sit up. He actually had, you know what we'll do? Instead of linking the article, we'll link his example video. He has one online from his clinic of performing this maneuver, and it makes a lot of sense. He had actually a lot of cool tidbits, such as for some of his cupulo, and this is not necessarily all backed up by evidence-based, but he had some of his cupulo patients, they'll hop up and down on one foot on the side that they're attached to, or have a head shaking type test or a maneuver before doing repositioning maneuvers. So it was very cool. He also had a good recommendation for treating horizontal canalithiasis at home by having them do a Brandt Daroff without head rotation. So they were literally just kind of lying down to each side with their head in neutral without turning anything, which is very interesting. I do want to go on though, because if I keep talking, we're going to be here all night long.
We've got another presentation after this, though.
We do, which we're very excited about. All right, so jumping into our next speaker. This was downbeat nystagmus associated with atypical posterior canal BPPV, differentiating cupulolithiasis and short arm canalithiasis and canal jam. I first need to say that Dr. Helminski just absolutely blows my mind when it comes to atypical BPPV. Her work is so interesting, and her video lectures are so interesting. I'm not going to do her lecture justice with a quick recap. But we should link her papers where you can read and visualize what she's proposing and what she's talking about. I'm a very visual learner, so I really greatly appreciated her slides and explanations as we went through her lecture. What I loved from her lecture was the options that she proposed for breaking down testing in atypical presentations of BPPV, as well as how to dislodge otoconia from posterior canal cupulolithiasis, which seemed very simple and effective. 39% of individuals presenting with atypical posterior canal BPPV will have previously been treated with a canalith repositioning maneuver for posterior canal BPPV canalithiasis type. So that's a lot. I mean, for the amount of people that we see with posterior canal BPPV, it seems like that there's a pretty high chance that they can also develop an atypical form of this at some point.
Which brings us to a good point here. You know, part of what we do is educate patients on BPPV, but one of the questions that always comes up when you let them know that this type of problem may recur is essentially, well, can I just do the same maneuver that I did before? And the answer is possibly, but we won't know unless we assess you. So it's much better to get a reassessment, make sure the problem is the same and requires the same maneuver, because something like atypical BPPV, which you just mentioned, may require some different positioning.
Oh, and let me just say that there are so many options and so many treatment things out there. Like, my toolbox is definitely getting a little full to the point where I need to start reviewing what tools I have now, because looking back, I'm like, that was a lot to take in. But I do recommend reading her papers. She did talk about sitting up vertigo, which I think we see a lot more commonly or more often, and than we care to admit. We kind of go like, I didn't see that. But we discussed the excitation of the posterior canal with return to sit, which has been deemed sitting up vertigo. and the possible mechanisms of why that occurs and what we can do for these patients. So again, it's easy to find her articles. I'll be sure to link those. But her lecture did make me feel a lot more confident when seeing something out of the norm. I feel like I've got a lot of those tools in the toolbox after this conference that need a little bit of reviewing and brushing off. But I actually got to try some of them out this week with a patient that I had with very stubborn BPPV. So I have to say it was a great success. Like I said, right from the conference to the treatment room. So that was a good thing. All right, I'm going to combine the lectures that Dr. Chris and Janky gave, mostly because this is definitely not my field, and I will not pretend to know too much about audiology aside from the wonderful audiologists that we've gotten to talk to and work alongside with. But not only is audiology not my strongest topic to talk on, but neither are kids or pediatrics. So she came and talked to us about pediatric vestibular loss and the need for multidisciplinary assessment, which I thought was very interesting. And she also, on the second day, talked about newborn screening and consequences of vestibular loss. So one thing that I thought was very interesting about Dr. Janky was she mostly sees vestibular migraine as the most common mechanism of dizziness in children, which is very interesting. She also disclosed or talked about these studies that are basically telling us there are two categories of kids who are at risk for vestibular loss. And this is kids who complain of dizziness and kids who have hearing loss, usually more the profound hearing loss. But I really loved hearing about the multidisciplinary approach to testing and treating kiddos with vestibular dysfunction and loss, just like our adult population. And it's best approached by a whole team of support for patient and their family. And there's a lot of education being done there to help, out as much as they possibly can. What was even more surprising was that the testing doesn't greatly differ in terms of what's available for kiddos, with the exception that certain testing should be performed with different age groups, such as, in infants versus toddlers. And she had a couple of really, really cute pictures of her own kiddos at a young age going through a rotary chair test and video V hit, which was really cute. I also learned about some new technology, which I was not aware of, up until this point. Not only did she talk about it in her lecture and showed what they did with that during studies, but the actual company that has this technology was there as an exhibitor. So this was the Synapsys Ulmer's Video Head Impulse Test. And the Synapsys V-Hit system basically is a remote camera. So instead of wearing goggles, you have a camera placed about 1 meter in front of the patient, and you distract them. You have some sort of a stimuli that you have them look at, and it'll actually measure the head impulse test remotely from that camera and look at testing in all canals and all planes, which is great for a kid because a lot of them don't want to wear goggles and have to mess around with that. So I thought that was really, really cool and interesting.
Very. Technology is crazy, and just the developments we've seen in the vestibular world alone in the last 2 decades even is incredible.
Oh, it was nuts. Another thing that I never thought about, and I thought was very interesting to share, was that 70% of people with Down syndrome have vestibular loss. And that's making me wonder, I can't say that I see a large part of this population in our clinic. And it makes me wonder why. I like that it was a little bit of thought-provoking and just very interesting, a new tidbit piece to learn.
And
Clearly,
also, couldn't that open up the doors then for providers who care for patients with Down syndrome? I mean, maybe this is part of the toolbox that is missing for these people.
yeah, you're absolutely right. If one thing was clear, it was that there's a need for increasing the number of qualified practitioners who assess and treat vestibular pediatric loss. There is not enough of those wonderful superheroes out in the community, and it made me feel a little bit less apprehensive to look into trying to learn more and treat this patient population, because I guarantee you it's everywhere we are. It's just there's not enough people to treat that. She also just stressed when it came to the consequences of vestibular loss, there's not a lot of studies that look at the consequences of vestibular loss. However, we do have studies that look at vestibular loss consequences in adults, which is linked to deficits in spatial navigation, spatial memory, visuospatial attention, executive function, and cognitive processing. So if you got a kiddo growing up without vestibular input, does that affect it? We don't know. There's another theory out there saying that you can't miss what you didn't have, right? You would think that'd be more debilitating for a healthy 30-something-year-old to all of a sudden lose vestibular function versus
Mhm.
a kiddo who spent their entire life learning how to live without it. So I don't know. It's very interesting that there's a lot of open space for research in that field.
I wonder too with kids, I haven't seen that many kids. I can think of probably 10 or less, and in some cases were very successful and other cases had me stumped. But I think even in kids, sometimes just listening, letting them talk, letting them explain what's happening can be such a relief from their perspective, finding a provider who is empathetic with them and allowing them to get it out.
Yeah, absolutely. All right. Forging ahead because I think we're losing our audience at this point. We got back to Dr. Teixido, who wanted to differentiate vestibular migraine from other vestibular disorders. This is like, I'm going to give you rapid fire, just fun tidbits I pulled from this and facts, which
Yeah.
I thought was very good. You ready?
Ready.
All right. So the time course of symptoms is an extraordinary variable. So with vestibular migraine, the pattern here is that there is no pattern. When something seems really funky and nothing can be correlated to anything and it just feels so random in their history, it's most likely indicative of vestibular migraine or migraine episodes. Migraine is very common. This is present in all ages, but predominantly in individuals in the prime of their life. Most migraine patients seen in otolaryngology offices will not meet the International Headache Society criteria, but will respond well to migraine treatment, which he did go into and talked about the different types of medications that he likes to prescribe and for different age groups. Like, it's a whole thing. It's amazing. It was so great to hear. He talked about the overall prevalence of migraine in the U.S. population over 12 years of age is 13%. So 13% of our population over 12 has
A lot of
migraine or
people.
migraine disorder. If this I thought was cool. Well, not cool. It's not a cool fact. It was just cool to learn. If one of your parents has migraine, you are 40% more likely to have migraine. But
Wow.
wait, there's more. If both of your parents have migraine, you are 90% likely to have a
Wow.
migraine disorder, which is very, very interesting. It kind of really shows how strong that genetic link is in this type of presentation. This was another thing I did not know. Effects from food triggers can be immediate or even be delayed days later,
Oh, wow. I didn't
which
realize that
then
either.
I did not realize that either. He said, think of food as trigger boosters. So you can have foods that you're sensitive to, but it's more likely you become symptomatic when you combine that with other triggers that creates this, combination effect into that threshold being
Yeah.
exceeded. 25% of migraine sufferers report attacks of vertigo. Migraine associated vertigo is 10 to 20 times more common than Meniere's disease. I think as a clinician, I always get worried that vestibular migraine or migraine related dizziness is becoming the new Meniere's diagnosis. And it makes me so nervous. But at the same time, it's really prevalent. It's just really prevalent. Nystagmus can be provoked in positional testing in 100% of symptomatic patients and typically dissipates when the patient is free of symptoms. So another interesting thing that we can apply to what we see in the clinic with our patients.
And makes it a little bit tricky knowing that these patients can have BPPV. What's BPPV? What's not BPPV with the
Yep.
nystagmus and positions?
Well, then this one will also throw you for a loop, but a VNG may show caloric weakness in this patient population in 15 to 35% of patients with migraine. So they might come in looking like a hypofunction or something funky, and in reality, that's not the case.
And by the way, then the next visit, they might present totally different.
Yes, they might have a follow-up VNG that's like, you've never had a hypofunction. Red flag. He also talked about how migraine patients typically cannot tolerate optokinetics and may have abnormal saccades during VNG testing. And a VNG test by itself may provoke a debilitating migraine episode. Headaches only occur during vertigo spells in about half of the cases. Patients may have a strong family history of migraine or unexplained fainting spells and motion sensitivity as a child. Rocking type dizziness is highly associated with migraine. And I think we talked about this before, but migraine is 3 times more frequent in idiopathic BPPV than BPPV secondary to head trauma or surgery. So he talked about a lot of times if you have these people that have these recurrent episodes of BPPV that come out of the blue, is there a migraine episode associated with that? So I thought there was so much takeaway. I can't even cover all the stuff that he talked about in his lecture, but I just gobbled it right up because I feel like I'm seeing all migraine nowadays. It's insane. So it was really good. It was very validating. I felt like I was armored with a lot more education to bring back to my patients, and it just made me feel good about what we were doing with this patient population.
Absolutely. And things to look forward to. We do have Dr. Kristen Janky coming on Talk Dizzy to Me. We've had Dr. Teixido on in the past that I had mentioned before. We might have to have him back on, given all this information that you've provided. And Dr. Helminski and Dr. Rizzik. I mean, there's so much to learn from these experts in our field. And I'm so happy that you were able to attend the conference and share some of the knowledge that you took in.
Yep. I mean, the last lecture that we had to touch on was with Dr. Helminski, and she talked about uncompensated unilateral vestibular deficits and also got into ocular alignment and treatment for that. Again, it's very detailed and difficult to get into. She did cover a lot of the work done by Dr. Michael Schubert up at Johns Hopkins, where they looked at some new things to kind of enhance VOR, enhance your exercises, like being in a dimly lit room and using a high contrast target like a laser. Different things that you can do to enhance the VOR, such as doing a near target, which is 15 centimeters from the bridge of your nose, or doing convergence and divergence while doing your gaze stability, which I thought was interesting. So she covered a whole bunch, even getting into looking at what type of progressive lens or bifocal lens your patient has and talking about how the shape of that could be throwing the patient off in terms of vision and eyesight, which is going to affect their vestibular exercises. So I thought that was very, very interesting. She talked about when to use a metronome, when to use different levels of duration, increasing the variability. Like, she had so much to add to this. Again, it's one of those things where, like, I'm not going to do it justice if I try to just lightly recap it. So definitely check out some of those references, and we'll link some of the things in the show notes to that. But wonderful, wonderful conference. I can't speak highly enough of it. And I know that Dr. Rizzik does updates, whether it's every year or every other year. I will be attending the next one just because it was so much fun. Smaller, more intimate. Again, having this multidisciplinary approach, truly so many different people from different backgrounds and disciplines there just made it 10 times better. So I can't thank Dr. Rizzik enough for putting that on. We might just have to have him on to just continue fanning him with all the compliments and to also ask him about his vestibular neuritis. But for sure, Abbie, you will not miss the next one. You will be coming with me, whether I have to bring you kicking and screaming, you will be there.
No, you won't. I won't be kicking and screaming at all.
Perfect.
I can't wait to attend the next one. And you said it perhaps is annual or every other.
I have to look that up. I should know this, but I do know that he's had a couple since I've moved down south here. So with it being only about a 2.5-hour drive for me, I'm more than happy to go up whenever he's hosting another conference because it was truly great.
Dani, thank you so much for sharing this knowledge with us. Thank you for attending it, and thank you for all the speakers at the Charleston Vestibular Conference this year. It sounds like it was a great, great presentation.
It was a blast. Don't miss the next one, everybody. And check out vestibular.org and their conference offerings if you want to look to see what next Vestibulaholic event is coming up for you. Abbie, thanks so much for talking with me tonight. We'll talk again soon.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.